Good morning, everybody. I'll be speaking on INTACS. I have no financial disclosures to make. So in this presentation, I'll be including the definition and specification of INTACS, the mechanism of action, how to plan the INTACS, and its different techniques of surgeries, the use of intraoperative guided OCT, and the complication of INTACS surgery. INTACS are arc-like polymethyl methacrylate intrastomal corneal ring segments that are surgically inserted into the deep corneal stroma to flatten the cornea. INTACS comes in different sizes, and it is potentially we can make different combinations that can be used to flatten the central cornea and reduce the astigmatism. Over the years, INTACS was introduced initially to correct the small amount of myopia, and it got FDA approval in 1999 for correcting myopia up to -3 diopter. But eventually, in year 2004, when INTACS showed its efficacy in cases of keratoconus, then FDA gave the approval for its use in keratoconus. The INTACS works on the principle laid down by the Barker's thickness law, which states that it's directly proportional to the thickness of the implant. It means if we put the thick implant, the stretching will be more and the flattening will be more. There are two types of INTACS ring. One is a regular ring, other one is a SK rings. Regular ring has a hexagonal transverse shape, whereas regular one has a oval and cross-sectional shape. Regular rings have an external diameter of 8.1 mm and inner diameter of 6.7 mm, whereas SK rings have an outer diameter of 7 and inner diameter of 6 mm. Regular rings come in various thicknesses from 0.25 to 0.45 in a step of 0.5 increment, whereas SK rings is available from 0.1 to 0.45 in a step of 0.5. INTACS has different role in different conditions. First in the refractive corrections, other one is a keratoconus and other form of ectasias, and now in post-LASIK ectasia also. So what are the prerequisites for INTACS in cases of keratoconus? Clear central cornea is needed because if there is a scar in the central cornea, it will obscure the vision. The other necessary thing is contact lens intolerance, because if patient is happy with the contact lens, we should not go for INTACS. The next thing is the steep K should not exceed 58 diopter, although now we are trying in more than 58 diopter also, but the results are not that predictable. And the pachymetry in the location of INTACS insertion should be more than 450 micron. Coming to the planning of INTACS, these are the essentials. First of all, we have to localize the cone. Then we have to calculate the mean refractive spherical equivalent. Then we have to look for mean K value. Other one, we have to look for superior inferior asymmetry, and we have to look for steep axis, and we have to calculate the thinnest point in 6 mm zone. So I'll go one by one. First of all, finding the incision depth, we have to mark the 6 mm zone in a corneal thickness map of pentacam. Then we, like in this map, the 507 is the thinnest point in 6 mm zone in which we need to put the INTACS. Then we have to calculate the 75% of this 507, which comes to be around 380. Another important thing, if thickness is coming more than 380, we have to take the depth as a 380, because if we put above that, then the effect won't be that good. Then localization of the cone. Cone can be divided into two types, centered cone and decentered cone. Centered cone, what are the centered cone? Centered cone means location of highest point of elevation within central 3 mm and or more than 50% of the cone is located within 3 mm zone. Decentered cone means location of highest point of elevation is away from central 3 mm area and or more than 50% of the cone is located outside 3 mm zone. Like we can see in the picture, in the first picture, this is a center cone, it's well within 3 mm area, whereas in the second picture, the cone is decentered inferiorly. Third is calculating the mean refractive spherical equivalent. We have to calculate the refractive spherical equivalent, and based on that we can choose the rings. Like if the spherical equivalent is less than 3, we can put lesser ring size like 0.3 to 0.35 mm, and if it is more than 8 spherical equivalent, we can use higher rings. And similar in the cases of SK rings. Mean K value we can look from the pentacam. Like if K value is more than 55, then we need to use SK rings because that has a better flattening effect. Superior inferior asymmetry is also important in planning single ring or asymmetric ring. So how we have to find this? We have to take the difference of mean of superior 3 contiguous point in 3 mm zone two diagonally opposite three contiguous points. If it is more than 15 diopter, then we have to use single ring. If it is less than 15 diopter, then asymmetric ring can be used. How to choose the correct axis? Incident axis has to be at the steep meridian. We can note on the axis from OPSCAN, pentagram, or refraction, and best has to be used. Sometimes steep axis has shown by topography is nasally or inferiorly. In such cases, tangential method can be used. In the tangential method, we have to follow the direction of the cone in which it is progressing. We have to draw a line along the direction of the cone. Then we have to draw a perpendicular line to that line, and that will show the incision location. This is a nomogram provided by the company. We can use this nomogram also. It is based on the spherical power. So rings can be of different combinations, symmetrical ring segments or asymmetric ring segments. Symmetrical ring segment means both the rings are of same size, and it is usually used in cases of centered cone. While in asymmetric ring size is of two different size combinations like 210, 350, it is usually used in decentered cones. So this is an example in which the cone is slightly decentered. So, but it is more than 50% is in the central theme area. So it will be considered as a centered cone, and we have used 450 ring symmetrical. And after the ring, this is the post of 1 month results, in which there is significant flattening, and the cone is shifted in more in the center. This is another example of the asymmetric ring segment use, in which the cone is decentered, and we use 0.4 with 0.25 rings. And after 1 month of the rings, this is a flattening we can see, and the cone is well in the center now. So coming to the surgical technique, there are two types of method which can be done, which can be used for the INTACS. One is a manual insertion technique, in which the learning curve is slightly on the higher side, and it has a high chance of complications like perforation or false track formation, and we need to put sutures also. While in femtosecond enabled INTACS, the cost is the main limitation, and unavailability of the femtosecond machine is another limitation. So this is the femto assisted INTACS, in which we need to feed the values, and then the femto machine will create the channels. Then after creating the channels, we can open the channels with the sectors on both the sides. Then we can put the rings. So coming to the interesting part, that is intraoperative OCT guided INTACS surgery. So with the help of intraoperative OCT guided, going in the false track we can minimize this complication. So after when we open the channels with the resectors, we know that we are going in the correct plane. We can clearly see the dissection of the corneal lamellae, that their plane is the same, not going inferior or superior. Then rings are inserted now, and this is the point when the chances of perforation is maximum, when we insert the rings, because we can go in a false plane or we can go above also. We can see how the lamellae are dissected and the rings are going inside the cornea. There is a uniform thickness of cornea above and below the rings. Similarly, the other ring is put. Although the INTACS surgery is quite safe, but still the complications sometimes occur. Like in this case, there is a vascularization along the channel, and in this case there is extrusion of the ring superiorly. There are other complications of infection, corneal melt, glare, halos in some cases, inflammation, and photophobia in some patients. So in future research, intraoperative ring adjustment or change depending on the topographic changes with the help of handheld topographer can be used. Corneal biomechanics needs to be studied between the regular and SK ring, how it affects the corneal biomechanics, and planning ring segment on the basis of Q value would be interesting. In conclusion, INTACS is no longer a best modality to treat low myopia. It provides its efficacy in the management of keratoconus, although the correct patient selection need experience. It is effective in cases of post-LASIK ectasia. Femtosecond assisted INTACS procedure proved its superiority than the manual surgery. Complication is a rare entity, but it still exists. And finding the best nomogram for your patient is always the most challenging. Thank you.